I'm not claiming any expertise in Canadian health policy, but my interest, I happened to be in Canada for a week or so, but one of the things I was interested in doing is making contact with people working in the area. There was a bit of a flush of work about 20 years ago, comparing the two systems. There's been very little since, and there's still a lot of interchange. We've had quite a few Canadian PhD students at the Menzies Centre, but very little work on this comparative dimension, which I hope will come out that there are a lot of both differences but from a base of a lot of similarities, which would be useful to compare. Often we make assumptions about the influence of both federalism and the particular shape of private-public relations in Australia, and more of a comparative analysis would actually get us a better idea of whether we're getting too caught up in our own sort of particularity and aren't realising that there are actually broader sort of confounding issues that are actually shaping the system. So what I'm going to do is quickly look at some of the issues around comparing health systems in a rather unsystematic way, a few general observations about Canada and Australia, and then look at the Australian case, but structuring this around some of the issues of comparing systems, and then look at the private health insurance example. So I'm going to take a little while to get to private health insurance because it can only be understood within a systems context, and it's not a very interesting subject on its own, but the way it shapes access and the way services develop. And then look at some of the consequences and a couple of the reform agendas in Australia, some of which you'd recognise here as well, I think. There is an industry, this is the less well-known comment on health policy it's the Australian Prime Minister looking puzzled next to him. The White House then corrected it and said actually he didn't mean that he liked universal single-payer systems, and then he tweeted and said, yes, I do, to confuse everyone even more. But there have been various ways of comparing systems. This is, I found, slightly bizarre version of, most of you will be familiar with the Commonwealth Fund survey. I don't know how it went down in Canada, with 9s and 10s, sort of the bottom coming close to the US on almost every score. Australia did very well, so of course it got wonderful coverage in the Australian media and from government, with healthcare outcomes #1, although a considerable number of them have nothing at all to do with the health system itself. And the most bizarre one was that the overall ranking went to the UK, which came second last in outcomes. So the findings, when you go through it, it's extremely efficient and equitable, and the processes are wonderful in order to get to quite mediocre outcomes. Again, a lot of which aren't actually that directly connected to the system itself. So it's problematic comparing, and I think picking particular variables like this is a particularly hazardous way of going. And the more difficult one is to try to look from a systems perspective, but I think that really is the only way of going, looking at how funding, access, service provision all fit together rather than pulling out fragments like the Commonwealth Fund. So just quickly looking, I hope I've got the Canadian dates right, but in the 1940s, both countries in post-war reconstruction had some grand visions and nothing much came of it. Australia was left with a national pharmaceutical benefits scheme, which is still going, which was set up in the late 40s, but blocked by the medical profession but implemented by a Conservative government in the 1950s. In the 50s in Australia, we got publicly subsidised private health insurance. You had to buy health insurance in order to get the coverage. And again, I think there are, from what I've read of Canada, there are provincial equivalent, was the Alberta model, fairly similar to that, of private insurance, but publicly subsidised. I don't know of anyone who's been able to set up a free market private health insurance system. So the mix of each system is what level of public subsidy is needed and what the mix is between public and private. So Medicare sort of emerges in the late 60s, early 70s in Canada. In Australia, a system called Medibank came in with the very reforming Whitlam Labor government. It was blocked by a hostile upper house and hostile state governments for several years and was introduced in July 1975. In November 1975, that hostile upper house used its power to get the Governor-General to sack the government, and a Conservative government came in, which then spent the next 6 years demolishing Medibank. And we went back to private health insurance in 1981, which was a complete disaster. And everyone breathed a sigh of relief when, in 1984, Medicare, pretty much the same as Medibank, was brought in. Very similar and actually heavily influenced by the Canadian model. One of the main architects, Dick Scotton, spent time in Canada in the late 60s. And so a lot of the debates around extra billing and questions like that were similar. The main difference was the Australian system is national. There are Medicare, which mainly funds medical services, particularly general practice, but also specialist medical services, is a national scheme, not a state one, and that's had quite a bit of difference. Private health insurance, the other difference was private health insurance was allowed to continue to cover medical services, but the assumption then was it would slowly wither away. Who would buy private health insurance if you could get good coverage for free on the government scheme? So Conservative governments again in 1996 to 2001 tried to restore private health insurance. Politically, they couldn't get rid of Medicare, but what they did was brought in rules that meant, which I'll look at a bit later, that forced people to buy private health insurance. So it's an interesting, the rhetoric was all about markets and choice. Most people didn't want the market or choice, and so they were fined if they didn't purchase the product that they didn't want. And many of them go to great lengths not to use the product after they've bought it. So the perverse policies element is there. Now, some of the similarities and differences get lost in these issues, but federalism is one key comparison. Australia, which designed its system to be not as centralist as they thought the Canadian was in the 1890s, somehow came up with a far more centralist system where fiscal powers, particularly taxation revenues, are totally concentrated at the centre, and the states are rather poor mendicants. What we call vertical fiscal imbalance is the states have to provide a lot of services. They provide all the public hospital services, a legacy from colonial days, but can't fund them and so rely on heavy subsidies and transfers from the federal government. We also have a powerful elected Senate, elected on proportional representation, and very often, as at the moment it's no one controls it. It's got a lot of minority parties. It's very rare for a government to control the upper house. In medical politics, the politics of the CMA and the AMA are very similar, and provincial politics also, or state politics in Australia, varies between the different associations. Some are more sympathetic to government action, some are very opposed, but across it there's a similar historical support for fee-for-service and for extra billing, which they were much more successful in getting in the Australian system. The other aspect of medical politics is that the Conservative parties in Australia have never fully reconciled to Medicare. They promised for its first 12 years to abolish it, and it was one reason why they couldn't win elections. They then swore they now supported it, but then tried to redefine it as a safety net for the poor with private health insurance for the rich. And that tension is still there. So I think there's much less of a consensus around Medicare in Australia and a lot more suspicion. So at the last federal election, at the last moment, the Labor Party, which supports Medicare, ran a completely dishonest scare campaign claiming the Liberals were planning to privatise Medicare. No one could actually explain what that would mean because no one would actually want to buy it. But this had a big effect in some seats, and it was a historic legacy that people are highly suspicious of the Conservative parties, and it is a health system that is very popular right across the board. Finally, I won't go into this, but because Greg's introduced it too, but there's a very similar transition in population health in both countries, posing new problems with health systems that in both cases were designed for a different era, and one much more dominated by acute disease, and linking up, integrating care across systems, reducing fragmentation are similar problems. Just looking at a few, I won't have too many tables and graphs, but I have a couple, and you can see here some of the differences across this one's, yeah, that's come out clearly enough. There are some interesting anomalies here. One is that surprised me was that private health insurance is actually much bigger in Canada as a proportion of health expenditure, and I would be interested to find out I'm not quite sure what it's being spent on. My overall impression is that it's for anything that isn't of any particular use medically, but there must be some other attractions for it. So the Australian amount, given the importance of it in political argument and actually the way it's helping shape the health system, is actually quite a small amount of health expenditure. It's about 7% and has been that way for quite a long time. And you can see there in both countries, general government expenditure makes up most of it. And private out-of-pocket, you can see in Australia, is quite high. It's one of the highest OECD, certainly of developed OECD countries, and just above the OECD average. If we look at the size of public and private sectors, they're very similar in both countries. But the difference when we break it down a bit, you can see the provincial governments, sorry, I don't have the same colour coding on these, but yellow for Canada is provincial governments, green for Australia is state and territory. And you can see there that's own source revenues. You can see there the much greater weight of the Australian federal government in spending compared to the Canadian. And the one result is the Australian system is, I couldn't find anything on Canada. You probably can't have as attractive a sort of ribbon graph as this, but it shows how complex the different funding movements are in Australia, and how there's no sharp distinction between any level of funding. They're all muddled up, and with the state and territory, the largest part of its spending is on public hospitals. So you can see that yellow flows largely going into the public hospitals, but and a little bit into sort of other areas of primary health care, most of which are linked to hospitals or mental health. But the Commonwealth, with its fingers in every area of the system, and using its funding superiority, even when others are putting money in, using its funding superiority to force them to adopt Commonwealth policies. So looking at Medicare, it's a little confusing because Medicare is often used to refer to that first pillar, which is the medical benefits scheme, which federal money funding medical services. And it's a fee-for-service system. There's a medical benefits schedule with about, I think it's almost 6,000 items on it. Again, I think that sort of model is familiar here, but it's one single national one, and with an amount set for each. There is one constitutional limit on the federal government is it's not allowed to set medical fees, which has been taken to mean it cannot ban extra, what you'd call extra billing. So what it does with medical services is it says, and again I think this was copied from Canada, if doctors send their bill directly to Canberra, they get 85% of the amount back, so less an administrative fee, but they are not allowed to extra bill. If they do that, we call it bulk billing. And the vast majority of general practice services are bulk billed that way. But there's nothing to stop a doctor charging anything they like, so long as the patient pays up front and then the patient goes and gets their medical rebate themselves. Again, I think that was one of the things the CMA pushed heavily in Canada in the early debates in Medicare. So it gives the Commonwealth, it's a very few specialists bulk bill, and so specialist fees often have enormous extra bills, and the variation in costs of services can be massive. There was just a study showing prostate surgery, you could get exactly the same operation, and depended on where you went, it was sort of $3,000 in one area and $15,000 in another. Not quite at US levels, but enormous differences, and no rationale behind that other than charging what the market would bear. Under Medicare, the Commonwealth gives money to the states to help with the public hospitals. In return, they are not allowed to charge. So public hospital admission is completely free. It's illegal to charge anything. You can use your private health insurance if you have it in a public hospital to get a better bed or see a doctor of your own choice, but that's completely elective. And so hospitals get more money that way, and so they try to find out if you have private insurance and persuade you to use it. And often people will, this is where people often hide the fact they've bought private insurance, because they'd then have out-of-pocket payments because they'd be in the private system, not completely in the public. It's a bizarre system. One of my students, when we were going around the class in a health policy class, they were describing what they did, and she described herself as a professional cost shifter. And we asked what she worked at a big public hospital. Her job was to find within the law, find out if someone had private health insurance, so she wasn't even allowed to ask them directly. So she'd have to talk around, there are certain benefits. If you were to have health insurance, you could choose doctors and things like that. And they then she'd try to persuade them to use it. An advantage of that for the hospitals and for the state government is that the medical charges are then billed to Medicare in part and to private health insurance in part, and so the Commonwealth government meets the cost, not the state government. So a lot, again, federalism, cost shifting between state and federal occupies an enormous amount of time. A previous Director General in New South Wales described herself to me as having world best practice in cost shifting was she thought was the best recommendation she'd had for her job. Finally, I won't go into it here, but there's the National Pharmaceutical Benefits Scheme, which has an independent committee that decides whether a drug can come on. There's a clinical efficacy and cost effectiveness analysis. No drug can go onto it unless there's been a positive recommendation by that committee. Government doesn't have to accept recommendations, but politically it's very difficult not to. So some of the descriptions of Medicare in Australia, again, will look very similar to the Canadian principles. The idea was basic medical benefits, that has been a contentious area. Treatment in a public hospital, as I mentioned, and regardless of income. And there was the notion of healthcare as a right of citizenship. Blewett was the Labor Party Minister for Health who brought in Medicare. So again, certainly on the Labor side, that notion of citizenship and universal health coverage have been a core principle, and it's probably one of the more, political system where it's often hard to tell the difference between parties. It's one of the real divides. I've probably gone through most of this, so the point I haven't covered there is private health insurance largely funds private hospital activity and it's subsidised by 30 or 40% rebate on members' contributions. So there's a big government subsidy, which is now means tested, but that was very contentious, and the means test is quite high. This is just, there are different models of private health insurance. So most systems I know have some mixture of public and private here. The Australian system, the Canadian one is quite separate from my understanding, with little or no overlap between mainstream medical services, Medicare and private health insurance. The Australian system is an odd hybrid. Medicare holds a monopoly over the funding of primary care. You cannot buy private health insurance to cover general practice, who are the gatekeepers of the system. To go to a specialist and get Medicare benefits, you have to go to a general practitioner and get a referral to the specialist. So the main entry point to the system is Medicare, and most of it is bulk billed, so most of it is free. In wealthier areas, you can pay co-payments. I know the highest I've heard was $120 for a 9-minute appointment with a general practitioner. You would have to have a very strong idea that money buys value to do that, but people do it. And I know parts of Sydney, there's little bulk billing because the clientele assumes that if it's free, there must be something wrong with it, and they can afford it. But in much of the western part of Sydney, the working class areas where most of our work happens, it would be hard to find a primary care clinic that didn't bulk bill. I mentioned that there was this assumption that with the end of with the introduction of Medicare, why would anyone bother with private health insurance? And this graph shows the first few decades, that history. You can see at the beginning there, can't get a pointer here, but the first arrow, Medicare, came in, and you can see a slow decline, and the abolition of Medicare is the second arrow, and you can see a bump back into private health insurance. Still not private health insurance. When it was the only system, it was still less than 80% coverage. It still was probably about 2/3, so about a third of people, when Medibank was abolished, had no coverage. And that was one of the reasons for bringing in Medicare. And you can see under Medicare a slow decline. Now the Labor side, which was in power much of that time, assumed this was probably a good thing and we'd see the end of it. Or it would become a very marginal thing for wealthy people to buy a better bed or something like that. They started panicking towards the end because health insurance doesn't slowly fade away and die into the distance. It goes into death spirals and crises, the sorts of things governments don't much like. Labor tried, by the bottom of that slump, private health insurance was heading into a death spiral where the people buying it tend to be the worst risks, the younger people, people for whom it's marginal expenditure and are not going to use it much, drop out of it, and so you end up with this spiral of the risk pool shrinks and the numbers of proportion of risks rises, and eventually any insurance system will collapse under that. In 1996, the Howard government came in, having promised he did a mea culpa, and he said, I opposed Medicare, I now recognise that the Australian people like it, I've learned my lesson, I'm now fully behind it, and abolition of Medicare is dead, cremated and buried. What they did was they tried to revive private health insurance and succeeded to some degree. What they first of all did was brought in the 30% rebate, a subsidy of private insurance rebates, and that pretty well stopped the decline, but it didn't increase membership. They did a few other things that didn't really work. The thing that really worked was they said if you don't have a certain level of private health insurance cover by the age of 30, you will pay an extra premium when you come into it. And that caused a panic because people were still not quite sure whether they were going to do something awful to Medicare, and then they'd be stuck outside the system or with more expensive premiums. You can see there the chute. It's very rarely in public policy. You can see the introduction of a policy and an almost immediate response. They had to keep the telephones at the private health insurance. They had to extend the deadline by 2 months because the backlog of people rushing into the system was so great. What they did, though, is they sell a minimum level of policies, which are known as junk policies, that get you over the rules. There's also a tax surcharge was brought in, so if you're above a certain tax level, you pay a fee, a fine, effectively, if you don't have a certain level of insurance. So the insurers sell a minimal level of insurance, which people don't actually intend to use, particularly if they're younger, and but pay it, and it's less than the surcharge they'd pay. So it's good for the insurance companies because they're getting a big input of money into the risk pool from people who have no intention of using insurance, but it's again a rather perverse policy outcome. So since then it's remained about that level. There's been some playing around with subsidies. Labor brought in means testing and some other restrictions, but it's probably gone up. It's a bit higher than that now. It's about 44%, so it's gone up a bit, but a lot of that, we don't actually know how many of those are junk. The amount of its contribution to the system is actually not enormous. You can see there, it's been about 7% and hasn't altered much over that whole period. You can see what has altered is the out-of-pocket payments by individuals, most of which is extra billing and dental. So I'll move on. Sorry, what time is it now?
Another 5 to 10 minutes.
Okay, I'll go through quickly some of the consequences. One of the consequences, because it's funding private hospitals, one of the consequences has been, as doctors can make more money using private insurance because they can charge what they like. If they're working in a public hospital, they come in on sessional fees, they can't do extra billing. If they're working in a private hospital, they can charge whatever they like. And what's happened has been a big shift towards private hospitals and a sort of reshaping of the hospital system. The rise of entrepreneurial, publicly listed, for-profit hospitals, which didn't exist before, and a shift so that public hospitals now dominate emergency surgery and they always say, and medicine, which I've never understood why they could do it. Medicine, what they mean is more complicated medical procedures. It's almost, a quick summary would be, anything in Australia, anything for which you can devise a good business model is shifting or has shifted to the private sector. So cataract surgery, you can see there the rise, separations of the, I don't know if Canadians use that term, but it's a hospital stay. And you can see there the rapid rise in the private sector there. And at the moment you can see the range of treatments that have moved from public to private. It's now becoming, these are a few years old, it's now becoming difficult to get chemo, for example, without a long wait in the public sector. Lens procedures, it's probably higher than that even now, particularly say cataracts, several years wait in the public sector, and you can do it, though it will cost you probably a couple of $1,000s out of pocket in the private sector, so people scrape and go in there. So it's focused on the bulk of services are still provided in the public sector, in general practice and funded federally, but the effect of private health insurance has been very focused on that for-profit sector and has encouraged a shift and an explosion in out-of-pocket and sort of extra billing payments in those areas. What does this mean for the attempts to reform the system? The Australian system is very fragmented, and one issue around chronic disease, mental health and areas like that is how do you bring the different pieces together to work better? And it's a central issue, for example, for state hospitals. How do we work better with primary care to get better linkage, information systems and transfers? Private health insurance is sort of outside that debate. Partly because it's not allowed to fund primary care, it will fund hospitals, but it can't do any linkage back into primary care. Some of the big commercial, sort of publicly listed chains of general practice have tried to link up with private health insurance, mainly to get more money, and it's clearly illegal and deeply politically unpopular, and the private health insurers have had to back off. So at that level, it's building in an area of fragmentation that's very hard to cross. The second one where there's actually quite a lot of overlap is the whole area that's at the moment very fashionable of value in healthcare. My centre actually gets a lot of money from private insurers and the federal government to work in this area. This was written by a colleague of mine who'd been working in the US and identified it was 13, they ended up identifying 100 low-hanging fruit of expensive, low-value, or even dangerous healthcare practices funded under the medical benefits schedule. And there's now my colleague Adam Elshorg's on the National Task Force, which is working through all 5,700 items with big clinical subgroups working on each of them and trying to eliminate them. A few reports have come out, but the government is still too nervous to say what it's going to do about it. This is obviously of great interest to the private insurers, and so there's a lot of overlap, and they've actually opened up all their data to researchers, and there's a lot of work going on around that because it's cost cutting is a major issue for them. So I'll just finish. I mean, those are the two biggest areas of reform. The first one, which I'm more involved in, private health insurance, is either outside the system or no one can really think how to involve it. There are a few people who've argued close down Medicare, bring in a Dutch system of competing private health insurers, and you could get integration. It's an economist's fantasy because the political transition would be impossible. So the challenge of sustaining a viable health insurance sector and private health hospitals alongside Medicare has gone back to the beginning of Medicare. Governments have tended to run away from confronting it. The two big inquiries, one into private health insurance in the late 1990s, explicitly said that the commissioners were not allowed to look at Medicare. They could only look at private health insurance on its own, which they actually protested in their conclusion and said everything they said needed to be taken with a grain of salt because you can't do this. Labor government in the 2000s set up a National Health and Hospitals Reform Commission, and its terms of reference said they were not allowed to look at private health insurance, which Labor was nervous about the politics of that. And again, there were problems in what they came up with as a result. There have been 7 big reforms of Australian health since the mid-1970s. Actually, there are now 9, and none of them have dealt with the public-private dimension. They've all focused on the public on its own. That rebate is going to, by the end of this financial year, will be up to $7 billion, and which is total health expenditure of about $140 billion. That's quite a lot. So, I'll end that there.